All right, let's talk about one of the most fundamental skills you'll ever use in nursing, advanced wound care. Whether you're cramming for a big exam or you're right there at the bedside, getting this stuff right is absolutely crucial. So let's break it all down.
So, how many times have you heard this one? Maybe from a grandparent, maybe even from older textbooks. It's probably one of the most common and honestly, one of the most dangerous myths out there. This idea that a wound needs to get all crusty and dry. Well, we're about to blow that idea right out of the water.
Because here's the deal, that's just not how the body works. The science is crystal clear on this. Modern evidence-based care has shown us that our skin cells, those little epithelial cells that do all the rebuilding, they need a moist, healthy environment to move around and close up a wound. A dry scab is basically a roadblock for healing. So the goal isn't to eliminate moisture, it's to manage it. Okay, so here's our roadmap. We're going to start with prevention and assessment, then we'll get into the body's own healing blueprint. After that, we'll cover the scary stuff, when wounds fail catastrophically. Then we'll look at the nurse's toolkit and wrap it all up with a quick exam-ready synthesis. So let's jump right into section 1, prevention and assessment. I mean, it's pretty simple, right? The best wound care is preventing a wound in the first place. It all starts with knowing what you're up against before it even happens.
Now, this is so important because these two get confused all the time. Friction, that's what you see on the surface. It's like a sheet burn, right? You prevent it by using a lift sheet, never dragging the patient. But shear, shear is so much sneakier. It's an inside job. It happens deep down when the bones slide but the skin stays put, literally ripping tiny blood vessels. And that is why keeping the head of the bed at 30 degrees or less is a non-negotiable safety rule. It physically stops the patient from sliding down and causing that deep internal tearing.
And here you can see exactly how that damage gets worse. At stage 1, you've got this red, intact skin that doesn't turn white when you press on it. That's a huge red flag for deep damage. By stage 2, the skin is broken and you can see that pink dermis. Stage 3 goes even deeper, and now you're seeing that yellowish fatty tissue. And stage 4, that's the worst case scenario. We're talking visible muscle or even bone. Now, if the bottom of the wound is covered in gunk, either that stringy yellow slough or hard black eschar, you just can't see how deep it goes. So we call it unstageable. Okay, listen up, because this is a huge exam trap. On patients with darker skin, that classic redness and blanching might not be visible at all. You have to rely on your sense of touch. Get some good natural light and then feel the area. Does it feel kind of mushy or boggy? Or maybe it's colder than the skin around it? Those are your most reliable clues that tissue is dying underneath. You have to use your hands. All right, now for a major exception to the rules. Normally, we want to get rid of that hard, black, dead tissue called eschar. But if you see a patch of dry, intact, stable eschar on a patient's heel, you leave it alone, do not touch it. Think of it as the body's own natural, biological Band-Aid. Ripping it off would just open up a doorway for infection, especially on a part of the body that already has bad circulation. Okay, let's move on to section 2. Now we're going to look at the body's own amazing healing blueprint. This is the playbook for how our bodies repair damage as long as we give them the right conditions to get the job done.
The body is incredibly organized. It follows a 3-phase plan. First up, hemostasis. That just means stop the bleeding. Platelets swarm the area and form a clot. Simple. Second is the inflammatory phase. This is the cleanup crew. The area gets red and swollen because the blood vessels open up to let white blood cells rush in and clear out all the bacteria and debris. And finally, the proliferative phase. This is the rebuilding stage, where that amazing beefy red granulation tissue starts to fill in the hole.
So how a wound closes is called its intention. Primary intention is the easy one. It's a clean surgical cut where the doctor just stitches the edges together, done. But secondary intention, that's when a wound is so big, like a pressure injury, that it has to heal from the bottom up and the sides in. It's left open, which means the risk of infection is through the roof. Tertiary is kind of a mix of both. A wound is left open on purpose to be cleaned out, and then it's closed up later. Now, the body can't just rebuild out of nothing. It needs supplies. And the 3 most important building blocks are protein, vitamin C, and zinc. You need them all. And here's another huge exam tip for you. If you want to know if your patient has enough of these nutrients right now, today, you look at their pre-albumin level. Albumin has a really long half-life, so it only tells you about their nutrition weeks ago. Pre-albumin tells you what's going on in their body today. It's the best indicator. Okay, let's shift gears. The tone here, it's a lot more serious. We're moving into section 3. What happens when wounds catastrophically fail? We are talking about true, life-threatening surgical emergencies. So let me put you in the room. You have a patient who is 5 days out from major abdominal surgery. They give a big cough, and then they look at you with wide eyes and say, "I think something just gave way." You pull back the blanket, and their incision has popped open. What is the very first thing you do? Your immediate priority. So this table breaks down the 3 big surgical disasters. You've got hemorrhage, which is internal bleeding. You're watching for signs of shock. Then there's dehiscence. That's the something gave way moment, when the wound layers separate. But evisceration, that is the absolute worst case scenario. That's when the wound opens up completely and you can literally see organs poking out. Your priority action is different for each one, but for evisceration, it is beyond critical. If you ever see an evisceration, you need to act instantly. There's a protocol, and you follow it to the letter. Number 1, and this is the most important thing, cover those organs with sterile gauze that's been soaked in sterile saline. This keeps them from drying out. Then you scream for help. Get that surgical team in there now. Make the patient NPO, nothing to eat or drink, because they are going right back to the OR. And finally, tell them to lie completely still. You have to memorize this sequence. It literally saves lives.
Okay, let's move on to something a bit less terrifying. Section 4, the nurse's wound toolkit. So we've done our assessment, we understand the body's process. What do we actually do to help? This is all about the hands-on stuff. Choosing a dressing isn't just about picking one off the shelf. You have to match the dressing's function to what the wound needs. Is the wound bed dry? Well, then you need a hydrogel to give it some moisture. Is it draining like crazy? Then you need something super absorbent, like a calcium alginate, to soak up all that extra fluid. Putting an absorbent dressing on a dry wound would be a total disaster. You have to know the why. Now, when we need to clean out a wound, we use irrigation, but it's got to be done with just the right amount of force. We measure that force in PSI, or pounds per square inch. The safe and effective range, the Goldilocks zone, is between 4 and 15 PSI. Too little pressure and you're not actually cleaning anything, but too much pressure and you can actually drive bacteria deeper into healthy tissue, making everything worse. So how do we get that just right pressure? There's a very specific recipe. The only way to guarantee you're in that safe 4 to 15 PSI range is to use a 35 milliliter syringe with a 19-gauge angiocatheter. Don't use a little bulb syringe, it's way too weak. And don't use a tiny syringe with a tiny needle, that creates dangerously high pressure. This specific combo is the standard for a reason. And that brings us to the end, our final section, the exam-ready synthesis. We've gone over a ton of information, so let's boil it all down to the absolute high-yield facts you need to walk away with. This is your rapid-fire recap. Okay, here we go. 4 things you absolutely have to burn into your brain. 1, for dark skin assessment, trust your hands. Palpate for changes. 2, if you can't see the bottom because of eschar, it's unstageable. And if that eschar is on a stable heel, you leave it be. 3, evisceration. Your first move, always, is to cover it with sterile, saline-soaked gauze. And 4, safe irrigation means one thing, a 35 millimeter syringe with a 19-gauge angiocatheter. Got it? You know, we've talked about a lot of rules today. But at the end of the day, a rule is just a tool. The real secret to being a great nurse is understanding the why behind every single rule. That's what separates memorizing from truly understanding. So the question I want to leave you with is this: how are you going to apply the why you learned today to protect your very next patient?